There are the ACOs. Many of you are engaged and involved in ACOs, Accountable Care Organizations. Bundled Payment Care Initiative improvement programs are out there. Bundled payment is here. You also have mandatory bundles with here, especially in the St. Louis marketplace, with the CGR, the Comprehensive Joint Replacement mandatory bundle is in place here as well. I can tell you right now from the Million Hearts campaign, there will be mandatory cardiac bundles coming very soon, guys. So if you have not looked at the Million Hearts campaign, go online there, Million Hearts campaign, that's CMS again. CMS again is providing cardiopulmonary resources for you as a provider and your care teams in order to, if you decide that you're really good at cardiopulmonary, you've got resources there to help you in evidence-based practice to help you redesign your organization. Because our payment methodology, all of us need to understand, our payment methodology is going from that bottom level there, what's called current FFS, fee for service. We're moving, and the overall goal is to say a global payment. I'm not sure if we're going to get there. However, what is happening is there's quality incentive add-ons, meaning if you do really good with your quality measures, especially that first one, that readmission measure, you will get a quality incentive add-on to your base pay. There are also then what are called episodic management, or also then you look at the shared risk in those programs where you have the ACOs and those bundle payments. And you in St. Louis, the greater St. Louis area, are absolutely actively involved in these payment models that are happening right now. And what that means is that the expectation is they're looking at your data and how you're going to get paid as you engage into these new payment models. And what that means for you is redesigning things within your organization to be able to meet and exceed those expectations. So the payment design models are here. They're there. They're really what's called a managed care type model, meaning working together, collaborating across all provider types, and how we take care of, number one, that patient, that resident, that consumer, and have the best patient and outcomes. This is just a quick picture of what's happening in the United States. And when you look at this is on that CMMI.gov, that CMS Innovation Center. All those blue dots doesn't mean just one type of a payment redesign that's happening. When you hit that blue dot, for example here, I put one blue dot, see what happened and exploded? One blue dot in one state, in one city, went over to 250 different payment designs that are happening. So what that means to us as caregivers and providers, not only are they looking at data, meaning CMS, OIG, as well as people who refer patients to you, they're looking at your organization data and how well you do, but they're also looking at how are you positioned in order to be in these new payment models and design, and how well are you going to do in these new payment models, and it's based upon your overall outcomes and your data. So as we move through value-based purchasing, there are a lot of changes. We talked about that there are clinical changes coming down. We talked about that it's utilizing data and technology and really being efficient and effective. How do you collaborate? And then also that there's payment redesign that's happening in our industry. And what you see on that road sign here is some of the expectations of the new payment model and the designs. So when we look at those market changes, as a leader and also as caregivers and working with other caregivers, we realize that there is changes in the workforce and the consumer changes are there as well. Our new consumer is multi-generational consumer. You've got everyone from the silent generation, World War II, up to actually some of you are taking care of the new millenniums. So you're taking and going across 5 generations and 5 different levels of expectation of care. No longer, how many of you in this room would like to be sitting at a table with someone that only takes a shower 1 time a week? Right? Okay, right? Would I like to? Would you like to sit next to me if I only took a shower 1 time a week? No, you wouldn't, okay? But think about that. We have to redesign some of our basic premise, the basic way we do things, because the expectation is different. And it's not saying that the silent generation in World War II didn't expect as much. The time and the world has changed. And internet technology and our expectations, because we keep on improving and want more, and we as parents want more for our children and want more for society, you're going to see these expectations and changes. The consumer wants to have a decision. They want to be able to purchase care based upon your outcome, just like they purchase a pair of boots on Amazon.com. And I'm not saying nursing home compare, home health compare, hospice compare, hospital compare is the best way to look at it. But again, what CMS and what the change is that there has to be some kind of platform for me as a consumer to be able to go in and say, I'm going to choose nursing home ABC for my mom because they have really good outcomes here. Not that it might be the right data outcomes, but at least there's a place for me to go, okay? So that's what the new consumer is looking for. We also have on the other side is the workforce. And our workforce together has got there are significant changes in our workforce. There are significant expectations. And again, in our workforce, we are working across 5 generations. So some of us still employ people that are from the silent generation of the World War I era. Some of us are still employing them. They're some of our long-term employees. There is nothing wrong with that. And there are people, we have people from the World War II and the baby boomer era. But remember, when we're communicating, we're working with our teams across the workforce, we need to also understand that we are human beings, and human beings taking care of human beings, working with human beings. And the number one thing we have to remember in the workforce era is that we have to engage and involve our teams. And we have to also show and talk to each other about what they want to contribute, how they can collaborate, what they can do to make a difference. It's not just about coming in and doing your job and leaving. And any of us as a leader think that that's what our team members are doing, you are so wrong. And I'm going to tell you that with all honesty and from the depth of my heart. Every human being wants to know what they did to make a difference and how they can contribute and how they can be and provide for the greater good. So when we look at workforce redesign, we have to look at that and how we collaborate across all levels. The other aspect of it is how we communicate with our workforce. If you're going to send out a memorandum to individuals that are in Generation X and Generation Y, are they going to look at a memorandum? Heck no. Are you utilizing Google Hangout to do your staff meetings in? Instead of doing an in-service where you're standing as an in-service in front of everybody, it's got to be interactive. There's got to be different ways. There's technology platforms that are out here. You have vendors that can help you with technology platforms and ideas. I'm telling you a huge thing, the Google Hangouts and the other things that are like that, to be able to get your message across. Doing podcasts. You as leaders, you might think, I don't know how to do a podcast. Trust me, if I can do a podcast, and I am from the baby boomer generation, so when I type a text, it's got to be full sentences, correct punctuation, correct spelling, right? And my kids, I have teenage kids, they're like, oh my gosh, Mom, my text is like this. Why are you doing that? They taught me how to do it differently. At least I text, but I am doing it differently. And I'm starting to use different modalities and mediums of technology. We have to do that in today's world. And with our workforce, it is a dynamic and changing workforce, and we know the shortages are coming. And how do we retain our staff? Retain them because if they feel like they can contribute, they'll want to stay. And that is the premise of what we do. If we look at how we contribute and how we work together and all these big, huge things that are happening, we do that together, we will make a difference. So how do we redesign and realign? How do we make that? We ask all these questions, look at how, why, what. What do we need to do, Lisa? There's so much happening. How do we do that? Can we remain status quo, guys? Can you remain status quo the way you're doing business today? No, you can't. It has to be changed. It is time for a healthcare revolution. We have to shake it up. We have to change it. We have to make a difference. And the way we do that is by redesigning foundationally in our organizations and how we present ourselves out there to the community, out there to our referring partners, and out there to all the other constituents that are very important to us in order to provide good quality outcomes. It is a revolution, guys. We in post-acute care are the hub of what's happening in healthcare. Hospitals want to work with post-acute care because they need to reduce costs. Hospitals need us. Your doctors need us. They need us. Post-acute care is where it's at. This is our opportunity to shine, and the only way we're going to do it is not sitting back on our laurels and saying, well, it's just the way we've always done it, guys. It is our opportunity to shine. We are RNs to RNs, administrators to administrators, everyone else, to make that difference. And how do we do that? We have to look at certain strategies. We have to assess our readiness. We have to also look at our clinical capabilities and competencies and our data and technology, and also partner and collaborate. When we look at our overall assessing our readiness, are we ready to make that change? If we are not ready to make that change, how do we sit back with our team and say at all levels, guys, this is what's happening. I listened to this keynote speaker. She talked about all these different things that are happening. I've got the PowerPoint, and I want to sit down and let's start breaking down some of these priorities that are happening. How do we do it and do it differently? Are we ready? Who are some of the best people in our organization that can influence change within our organization? Take the blinders down. You have got to be the change agent, guys. It doesn't matter what level you are in the organization. It's what we need to do in order to survive and prove to everybody how darn good we are in long-term care and post-acute care. We also have to utilize our data and technology, that data that's available to us, to really show and prove to everybody our value and worth. Work with our vendors, work with the other individuals that can help us with technology. Why are we not utilizing telehealth within our skilled nursing facility settings to do assessments so that someone doesn't go back out to the hospital, right? There are other opportunities for us. We have to look at our overall organizational data, and I have a list here of the data that minimally you should be looking at in order to position yourself for the future. When you look at your average length of stays, and you look at your disease state management, your readmission measures, this is data that's available, and this is a minimal expectation for us to look at and to be able to provide that information to our referring partners and our other partners in care. We also know that there's data available through cms.data.gov, and you have that in your handouts as well. We also know that we have accessibility to different data on a daily basis for us as providers. That's there. If you're not on an EHR, you still have data platforms to be able to pull from. If you as a caregiver in this room have never seen any of these reports, this is your time to talk to your administrator and your director of nursing. You need to know these because this is an outcome of the care and services that you provide on a day-to-day basis. Again, collaborate across all levels of the organization. Your clinical competencies, looking at those disease states, looking at are you ready and able to handle those disease states? Do you have evidence-based practice and policies and procedures in place? What do you need to do? Again, these are tools and strategies to help you as a leader to redesign for this new healthcare revolution. How do you assess your readiness for that change? And here are some things to take a look at. The biggest thing is create subject matter experts. If you have someone that loves cardiac rehab, talk with that. That might be your third shift RN working on Wing A that did that 3-4 years ago, and she loved it. And then you looked at your data and you realized that cardiac rehab is where you got to go. That's the person that you need to help you. And as a DON, as an administrator, that's the person that has to help create that team and redesign those programs within your organization. It's that same thing, looking at your capabilities and your competencies. And again, competency test where you're at. Competency test your nurses. If you have not done competency testing, I don't care what care setting you are at, competency testing at a minimum on an annual basis. Do you want to know what you need to do competency testing on? First person you should be talking with, your doctors and your acute care partners. They will tell you what they have to do as competency testing. You'll want to do very similar so that it shows that you're a partner in care working together. Because when you partner and collaborate, you are coming together, meaning hospital, physician, anybody in post-acute care, you're working together for the overall outcome of my health care. Because I, as a consumer, are purchasing care and I expect certain things. And I want you all to communicate. I don't want to have to be frustrated and walk around with volumes of paper between provider and provider. I want to know that you're all talking and communicating with each other, that you're collaborating, that you're documenting everything that's going on so that, again, redesign the way we do healthcare. Knowing that you have a core team to partner and you create that partnership team within your organization and you go out and show everyone how good you are. Use your data. It is time to revolutionize what we do and not stay status quo. We, as post-acute care, long-term care, have got to say we are not living by state survey anymore. It is about, we are going to show everybody our value and our worth and how good we are, because when you do that, and I can guarantee you, every organization that I've seen that's done that are extremely successful, and they will do very well and will have good amount of consumers coming in, will have good outcomes, and financially will be doing well, even though we are in an environment where it seems like financially things are being taken away. I've seen it, it's happening, and it's happening in your current marketplace right now. Create your strategy for growth, working together as a team across all the organization. Looking at how you make that change, looking at your value proposition, because you know what? Innovation is here. It is time for us to redesign. It is time for us to look at things, doing them differently, looking at maybe creating assessment units. And in that assessment unit, we work with our vendors and we have telehealth in there so that the doctor can do a quick clinical assessment in that assessment unit where the patient's in there, you've got robotics, you've got the cameras, you've got everything else. And I can tell you right now, if you have a good partnership with your acute care partner, they will pay for the technology in your setting. It is time for you to redesign. Do not sit back on your laurels. It's time for us to change and show to everybody that we are different. Because you know what, as we're sitting here, it's already transformed while we've been sitting here. Someone's out there partnering, it is a change, and a lot is occurring. So I love this little thing, it is true. Our industry is transforming as quickly as we're sitting in this room. But it is a great, exciting time for us as leaders. Put on that seatbelt while you're in that driver's seat, hang on. It's gonna be a fun ride because you know what? We can create the change. As I end here today and open up for question and answers, we can create that change. I call it create leadership, guys. And no matter what, I would print this one out. I would have that sitting in your desk. I would have that as caregivers and having conversations. We are the change agents in post-acute care. We cannot sit back and say, this is the way we've always done it. We are the change agent. We can refine and shape this culture and make the change. We can do episodic disease state management and choose how we specialize in our marketplace. Because if you always say, I provide rehab services 7 days a week, I provide nursing care 24/7, guys, you know what? That's an expectation. That's your license for Medicare and Medicaid, guys, all right? If you're accepting Medicare 24/7, 7 days a week, that's an expectation. That shouldn't even be in your marketing material anymore. You should be looking at specifically what you do, what you're known for, how you redesign, the high technology that you use, the great caregivers, the good outcomes. Have dashboards that show your great outcomes, show your average length of stay, your readmissions, show about what your caregivers are saying about working there, how people are working together. Have that. That's what you need to do. We redesign and reshape the way we do business. Again, think big. It's our opportunity, and no matter what, be energetic and have that passion. Because you know what? It is our opportunity to shine in post-acute care, guys. It is no longer the stepchild of working in a nursing home, no longer the stepchild of going to home health because you think, well, it was too hard to work in the acute care setting, so I'm going to go to home health. Ladies and gentlemen, that is not the way it is now. Post-acute care is where it's at. Skilled nursing facilities, you are the clinical arm of your hospital and of your physicians right now. Home care and skilled nursing should be working side by side. Senior campuses should be wanting to be actively engaged and involved because you want to keep the individuals on your campus, but you want to have a good quality partner to engage and involve and change. So be energetic and passionate because it is value-based purchasing. It is the road for us to be able to be the #1 care providers across the United States. So it is our future of healthcare. It is a revolution. It is redesign. There's a lot happening, but there's some great opportunities for us as leaders. So again, I want to thank you, and if anybody has any questions, I'm open up to answer some questions here before we end. Any questions?
What was that website? CMMI.gov?
CMMI.gov. It's the CMS, the Centers for Medicare and Medicaid Innovation. And that is a great website, guys. You'll love it because it'll talk about everything that's happening. You can actually go in there and look at what's happening in your marketplace. You can, remember that picture that I showed with all the dots? You can actually go into the St. Louis area, click on the dots, and you can see who's already partnered, who's already engaged in these different alternative payment models or methodologies. They are available, and it's right there for you. It tells you exactly what the model is, when they started, and also to realize, guys, all of you, that there is another set of next generation ACOs that will be announced here in July, very soon here, and CMS has anticipated there's over a 300% increase of next generation ACOs. Also to let you know that the Healthcare Task Force, it's another website, guys, if you want to be on, it's called the Healthcare Task Force. Healthcare Task Force, and what that is a group of constituents, meaning payers, meaning like the Humanas, the Blue Cross Blue Shields, Aetnas, all them, as well as then you're looking at CMS, and then you're looking at providers, and then you're looking also at people that are running these different alternative payment models, are involved in what's called this Healthcare Task Force, and what they're doing is they're helping redesign the commercial carrier products. So meaning our Medicare Advantage products are going to change, and there's new Medicare products that are going to be rolled out in January as well. But the one thing about that is they have agreed that they will follow the same premises of value-based purchasing of what CMS is looking at, and they will utilize the same quality measures, if not more, but they will utilize those same quality measures. So what's the good news about it is at least all these entities are starting to say, we can't have 23 new measures coming at once to everybody all the time. We've got to start working together and start having the same measures across all of our different payer types. So that's happening.
So we have time for about 2 or 3 questions. We have about 5 minutes left. And we've got 2 people that will be coming around the room with the microphone, so everybody's heard.
Well, one of the things that is very concerning to me is that if you look at certain questions for patient satisfaction surveys through hospice and stuff, the questions are ridiculous. And they don't, you can't answer them properly. So for instance...
They're very subjective.
Yeah.
Yes, very subjective.
For instance, they have one, did your loved one or whoever was on hospice have shortness of breath? The answer is no. Okay. The next question is, were you educated about the medications for shortness of breath?
I know.
How do you answer that question?
I know.
No. But if you answer no on that second question, you get a 0.
I know. And that's,
what is that? I mean, who made that up? Why can't you have a not applicable? It doesn't make any sense. So, I mean, that's not the only question that leads into a completely illogical. It's like, well, how do I answer that? Well, of course I wasn't, because there was no shortness of breath. So these are the kinds of things that, and you only got, 5 questions. So your entire survey is completely messed up because of that question. And the other aspect, of course, is crazy patients. Does anybody have crazy patients?
Nobody has that. Nobody has that actively engaged consumer and family member either.
Right. Crazy families, and you've done everything bent over backwards and your best and absent, and they're like, you're terrible.
Well, and to your point, and thank you for bringing that up, I was actually out in California at the National Hospice. There was a big group out there, and we were talking about the hospice quality reporting that's coming up. And part of that, talking about the CHAP survey and talking about those questions, and actually those questions actually came out specifically. And there were individuals from CMS in the room, and they said that while we realize that from the data and statistics standpoint, it's difficult to ascertain the appropriate scoring system, it is being taken under advisor and consideration.
Oh, great. To me, that's not difficult. It is you need a not applicable as an answer, and then that question is disregarded.
But I do have to say that it has gone back to a technical expert panel for redesign.
Oh, so it'll be done in a couple of years?
Yeah, I know. And then the problem and the difficulty is, and all of you as leaders here, also take a look at the hospital consumer engagement. Their platform, it's the same thing, and they're up in arms as well, just saying, well, you created this great survey process, but however, you've got conflicting questions that will ultimately affect my score, and then it goes into your total performance score, which ultimately affects your base payment. Because these total performance scores in our 5-star affects our base payment, that fee-for-service base payment, because fee-for-service isn't going away yet. It's still there with a quality incentive add-on, and that's where so they reduce that base payment. And then the quality incentive add-ons are your consumer engagement score, your readmission score, all the quality measures that are coming out. That's what they're looking at until we can move to a global payment, which I don't know if that's going to happen or not, but a global payment. But in the meantime, so we have fee-for-service quality incentive add-ons. You got on top of this as leaders how we're going to try to do our business, because now we don't just have Medicare bills, we got to look at it completely differently. We got that next level. If you're engaged and involved in an alternative payment model like ACO bundle payment, or you're involved in a narrow network where they have certain payment methodologies, you've got that level going on. And then on top of it, you got the commercial carriers. So if you accept Medicare Advantage, other things, it's all sitting there too. So as a leader, you're like, oh my gosh, how do I do this? What I say to you, go back to your basics, go back to your core foundation, go back to your current data outcomes, make your performance improvement, look at where it's going with those performance outcomes, and position yourselves for the change. We can't change that tool right now, it's going to be changed. However, we can look at everything else around that and try to create that solid foundation, and that's what we have to do. But I do agree with you, those tools are, and the new care tool that's coming out is very interesting as well, so, yes?
As Dr. Floyd talked about changing those rules, I'm here to speak that you can get those rules changed. We work in one of those innovation grants, and we've been consistently telling CMS that if you want the nursing homes to take care of these med-surg patients, which they are very ill, frail, and vulnerable, you need to pay nursing homes more money. They listen to us. And so for the next 4 years, we have a grant where our 16 homes are going to receive additional money for taking care of 80% of the diagnoses that lead to hospital transfers. That can become a national model. So I say to you all, when you don't like the rule that Dr. Floyd just talked about,
Find a way.
don't stop telling them. If you go away, they're not going to have that pressure on their back. Every month we talked about the fact that you've got to have money so nursing homes can take care of these sick people. So I just encourage you to to continue to make your wishes known, because it worked on our end.
And thank you for bringing that. As we end today here, because we're going to be moving to the next aspect of your very action-packed filled day. Innovation is here. There are different monies and opportunities. You have a peer right here, right now, that if you're interested in that, spend some time with her to learn about that. There is money available, there's grant money available, there's district grant money available, QUIP grants available that are out there to help you redesign and re-innovate your organization. No matter what provider type you are, guys, it is a revolution, guys. And if we're not on top of it and making that change, it's gonna happen to us through regulations, and it's the last thing we want to do. Because we know we can provide the best quality care and services. We've got to be ahead of that bell curve, get in that driver's seat, put on that seat belt, and go for that good ride. Because it is going to be a fun ride, scary at times, but it is going to be a fun ride because it's our opportunity to shine and look at that road ahead. Thank you.